Good afternoon, guys. If you are just seeing me for the first time, I welcome you to my page. In today's episode, I will be demonstrating on how to rupture the membrane during labor. Like, ịgbapụ mmiri nwa mgbe nwaanyị nọ na labor. That is how we used to say it in our language. As a midwife, when a woman is in labor and the labor is not progressing as it's supposed to be, and her membrane have not ruptured, it's not every woman that their membrane ruptures before they go into labor. Some will labor till 6 cm, 5 cm, 7 cm, and even 8 cm, and their membrane will not rupture. So we midwives, we rupture the membrane to facilitate labor, okay, to enable the labor to be fast. Again, we rupture the membrane to be able to examine the levels of the membrane, like to check if the woman has oligohydramnios or polyhydramnios. And we also rupture the membrane to examine if there is any distress that will be detected from the baby. Like if you rupture the amniotic fluid and you check the fluid and the fluid is clear, the woman does not have any problem, the baby does not have any problem. But if the membrane is greenish, okay, it shows that there is a fetal distress, the baby is in distress. But if the amniotic fluid is blood stained, it shows that there are some issues with the placenta, okay? Now, before you carry out this procedure, you must check the fetal heart of the baby first, okay? This procedure, I will be using, this is my examination glove, then water resistant pad for the woman. Then I will be providing this instrument as amniotic hook. Then this is sponge holding forceps. I will use it for vulva swabbing. I will use it to swab the vulva before the procedure. Then I will be providing this ball as the head of the baby, and this waterproof full of water as the amniotic sac and the amniotic fluid. Before you carry out this procedure, you will explain this procedure to your patient, okay? Then you ask her to empty her bladder. Then you wash your hand and dry them, put on your gloves or even have extra gloves. Then you position your patient in a lithotomy position. This is lithotomy position, or in a dorsal position. After positioning your patient, we are going to provide the opening of these clothes as the vagina. Okay, the vagina is the first opening that you will insert your hand into. Then the foam inside, we are going to provide this foam as the hose, the mouth of the cervix. Okay, so now you will first of all carry out vulva swabbing using the instruments I provided. As a midwife, we know what is vulva swabbing, or as a student midwife, you should be familiar with vulva swabbing. That is cleaning of the vulva, the outermost part of the vagina, to avoid introduction of microorganisms into the internal holes or inside the vagina. Okay, now you first of all carry out vagina examination after vulva swabbing to examine the opening of the cervix, and also to detect if the head of the baby has really engaged, has descended well. Because in amniotic fluid rupturing, in membrane rupturing, you do not rupture if the head of the baby is still up. Like if the head of the baby is not well descended, is not well engaged, you do not rupture. You only rupture when you can access the head of the baby. So you carry out vaginal examination, then insert your finger inside the cervix. Okay? Holding the fundus. The fundus will help you. Holding the fundus will help you to position the head of the baby properly. Then I have already assessed the head of the baby. So I've already known where to insert my finger and where not to insert. Now I've already assessed the holes. I've already located the head of the baby. Then using my left hand, depending on how you make use of your two palm, you insert your two fingers to locate the holes and the head of the baby. Then, using your amniotic hook, just like I said, I'm going to be providing this instrument as amniotic hook. Okay? you will insert it into the os through your fingers. Okay, like this. Let me bring it out so that you understand. Okay, this hook will go through your fingers like this. Okay, the essence of allowing your finger to be inserted into this place and placing this hook on top of your finger is to guide you so that you will not injure the woman. Because if you look at the mouth of this hook, it has a teeth. Okay, and to avoid injuring the baby in the womb, the head of the baby. So that is the essence of allowing this instrument to go through your fingers to the os. So I'm going to be demonstrating what is happening inside that os, okay, inside the uterus. So just like I said before, we are providing this opening as the opening of the os, okay, the cervix, not the vagina. Then we are providing the ball as the head of the baby and the water here as the amniotic sac and the fluid. So as immediately you insert your finger, your two finger inside the os, get the camera this way. This is what you will be getting. This is what will be happening. Okay, bring the ball closer. Okay, your hand will just be touching the head of the baby. Okay, that is what is happening inside the os. Get the camera of how my hand is. So this is it. So in this procedure, some school of thought will tell you that it is better to rupture in contraction free period. Okay, but I myself, I prefer to rupture when contraction is bound or at the height of contraction. Okay, reason is because now if you look at the head of the baby here now and the amniotic sac and fluid, this is an example of contraction free period. The woman is not contracting now. The uterus is not contracting. Everywhere is relaxing. Now, if I happen to attempt rupturing, now that contraction is not bound, I am likely to cut the head of the baby because the head will just be, just hold it for me. The head will just, you will meet the head. No, just hold the thing like this. You will just meet the head. Okay? This is what is happening. My instrument is touching the head of the baby direct. But when contraction is bound, why I prefer when contraction is bound, hold it, okay? But now that the contraction is bound, you can see that the head of the baby is now separated from the amniotic sac. The amniotic fluid and sac is what is presenting. When you touch them, this is what you'll be seeing. You'll be feeling the sac, okay? So that is the best time to rupture to avoid injuring the head of the baby, okay? Then you rupture. You see it, then the water will now begin to flow. You will see the water coming out from this os. Why you will not see it coming out from here? Okay, this is it. The water will just flow like this. Then you will put your hand to get some of the fluids. The essence of getting some of the fluid to your hand is for examination. Just like I said before, you check for the color of the liquor. If the color is colorless like this one, there is no problem. But if it is blood stain, it shows that there is complication with the placenta. But if it is meconium stain or greenish in color, it shows that the baby is in distress. So in a situation like this, you try to review to find out what is wrong with the baby. Now, immediately after performing this procedure, you know the amniotic fluid is divided into two during labor. Okay, we have four waters and the hind water. What we actually rupture is the four waters. The hind water will come out. The remainings of this water will come out immediately the woman pushes the baby. You find out some water coming out with the baby. Before you carry out this procedure, you ensure that the fetal heart of the baby is in good state by checking it. Then after the procedure, you check the fetal heart again to ensure that it is still normal. Then another reason and another purpose why you must check the os, why you must do vaginal examination before you carry out this procedure is for you to rule out placenta previa, placenta abruptio, cord prolapse, or any deformity, and also check the level of dilatation of the cervix. Somebody like me, I prefer rupturing once it is up to 7 cm. Okay? If you found my video interesting, please touch my follow button and share this video for more. Thank you.